Good afternoon, everyone. So these are results from a multi-center study that was done in Tanzania and in Ethiopia. And it included HIV-positive patients who were co-infected with tuberculosis. We concurrently recruited 427 patients with equal sex distribution. 44% of the patients were smear positive on sputum microscopy. Generally, these patients had a low BMI, and Ethiopian patients had proportionately more Ethiopians who had a BMI of less than 18.5. These patients were severely immunocompromised. However, Tanzanians had statistically significant higher cell counts compared to the Ethiopian patients. There was a parallel cohort of HIV-only patients that was also recruited at the same time, and results of this have already been published. So at 4 weeks after starting the antiretroviral therapy, the efavirenz concentration among these patients was found to be 1.6 nanograms per ml, and Tanzanian patients had a non-significant lower concentration compared to the Ethiopian patients. Females were also seen to have higher concentrations compared to the males, and patients with a low BMI were also found to have low efavirenz concentrations. At 16 weeks after starting the antiretroviral therapy, there was no difference seen in efavirenz concentrations between the two countries. However, females were also seen to be found to have significantly higher efavirenz concentrations compared to the males. No such differences were seen in relation to the BMI at week 16. Nearly a third of the patients were found to have subtherapeutic efavirenz concentrations. So the CYP2B6 genotype frequency was similar between the Tanzanians and the Ethiopians, and 50% of the patients were found to have the CYP2B6 rapid metabolizer genotype. The CYP2B6 frequency was significantly different in relation to the efavirenz plasma concentrations, where 71% of the patients who had subtherapeutic efavirenz concentrations were found to be among those who had the CYP2B6 rapid metabolizer genotype. Half of the patients had the CYP3A5*0*0, and these were all found to have subtherapeutic efavirenz concentrations. Now, regression analysis revealed that cytochrome 2b6 was a significant predictor of efavirenz concentrations. 44% of patients had both the CYP2B6*1*1 and the CYP3A5*0*0 alleles, and patients who had both these alleles had a 2.2 times the higher risk of having subtherapeutic efavirenz concentrations. Patients with higher baseline CD4 cell counts had a decreased risk of having subtherapeutic efavirenz concentrations. And there was also a trend showing that males had a tendency of having lower concentrations compared to the female patients. There was a good immunological outcome in this cohort, and predictors of good immunological outcome was low baseline viral load levels and high baseline BMI. The box plot figure shows differences in efavirenz plasma concentrations between the Tanzanians and the Ethiopians among those who had HIV only and those who were co-infected with tuberculosis. As you can see, there were significant differences in the plasma concentrations among the HIV-only only patients. However, among those who were co-infected with tuberculosis, this difference was not seen. So in conclusion, our study found that CYP2B6 and CYP3A5 appear to be the primary determinants of plasma efavirenz concentrations among co-infected patients. And after adjustment of these alleles, there was no difference in efavirenz concentration by country, suggesting that other genetic differences may not significantly contribute to efavirenz metabolism in the presence of rifampicin at a population level. Thank you.
Thank you very much. We are going to keep all the questions for the discussion later. So the next presenter is Dr. Gahoe. I'm going to read it. Ready? He's going to present a randomized open-label balanced two-treatment single-dose crossover all-bioequivalence study of lopinavir-ritonavir granules 4010 with Calitra, lopinavir-ritonavir oral solution 80-20 per ml in normal healthy adults under fed conditions. Wow. I think I breathed once. But you don't need to repeat the title.
Thanks, Martha. Good afternoon. On behalf of the co-authors, I'm here to present bioequivalence study data of new formulation, which is lopinavir-ritonavir granules, versus the currently available reference product, which is an oral solution. As we know that the lopinavir and ritonavir is frontline ART for the pediatric population. This formulation can offer easy-to-use alternative for the small kids. The objective of study was to compare the relative oral bioavailability of the new formulation, which is granules, versus the reference product, which is an oral solution. The design of a study is open-label, randomized, two-treatment, two-period crossover, single-dose evaluation in adult healthy volunteers under the fat condition. Under the each study, either the dose of the granules, which is a test product, is given, or the reference solution is given. And the subjects were monitored throughout the study for the safety and tolerability, and at the same time, serial blood samples pre-dose and up to the 36 hours post-dose were collected for the each period. Validated analytical methods were used for quantification of drug concentration in plasma. The pharmacokinetic parameters were computed using the non-compartment model of Vinlonin, and the statistical comparison of the parameters for both the formulation were carried out using the ProcGLM from the SAS. This is how the pharmacokinetic results look like for the lopinavir and ritonavir components. In order to be bioequivalent, the new formulation to the oral solution, the 90% confidence interval should be between 80 to 125. So if we look at the lopinavir component, the 90% confidence interval for the Cmax and the AUC parameter is within the acceptable range. And as we move to the ritonavir component, once again the 90% confidence interval is within the acceptable range, which is for both the parameters, Cmax as well as the AUC. So as we go ahead and conclude that the test formulation, which is a new formulation of granules, and when it is evaluated under the fed condition for the bioequivalence against the oral solution, it is found to be bioequivalent from the rate as well as extent perspective of absorption. The single dose of granules, which is the 2 sachet of 40 by 10 mg granules, and the reference oral solution were well tolerated under the fed condition in the subjects. And we hope that the new pediatric formulation, FDC, could provide an easy-to-use alternative for the small children. Thank you.
Thank you very much. And the next presentation is again by Dr. Gahoye about single-dose fed bioequivalent study of lamivudine, tenofovir disoproxil fumarate, and dolutegravir tablets versus epivir, Viread, and TVK in healthy volunteers. I cheated. I didn't say the doses, please.
Thank you, Martha. I thank my co-author for the study, and as the name looks quite long, I think it's difficult to spell, so we can understand how the patients, they take different individual medicine, how difficult it is for them. So the approach here is to develop a fixed dose combination with an objective to improve the patient compliance. And the three ingredient actives, which is lamivudine, tenofovir, and the dolutegravir tablets. They were clubbed together as fixed dose combination, and a bioequivalence study was conducted against the individual reference product, which is epivir, virad, and the TVK. So the objective of this study was to compare the relative bioavailability, oral bioavailability of the fixed dose combination and the separate reference product at the same dose. The design is the open label, randomized 2-period, 2-treatment, crossover, and single dose evaluation under the fat condition in the healthy volunteers. In each subject, once again, either the test product, which is a fixed dose combination, or all 3 individual reference products, they were given to the subjects, and the serial blood samples were collected up to the 72 hours of the post dose. All the analytical methods were validated for both for the quantification of all the 3 actives in the plasma. All analyses were performed using the 96-val liquid-liquid extraction with the HPLC and the tandem MS. The limit of quantification is 40 nanogram per ml for dolutegravir, 25 for lamivudine, and 3 for the tenofovir. The acceptable criteria for bioequivalence was for the all pharmacokinetic parameters, Cmax, AUCL, and AUC infinity for the test and difference should be within the 80 to 125. It was a single dose pharmacokinetic study where the parameters were calculated using the non-compartmental technique, and the statistical study analysis were performed using the Lin-Lone PROC-GLM. This is the pharmacokinetic results for tenofovir, lamivudine, and dolutegravir. Once again, the acceptance criteria remains the same, where the 90% confidence interval for individual drug component should be within the 80 to 125. As we see for tenofovir, the first one, and for the dolutegravir, and obviously for the lamivudine, in all 3 cases, the fixed dose combination, which is a test product, shows the comparable behavior with respect to the 90% confidence interval. This is within the range of 80 to 125. So here we conclude that the new formulation, which is a fixed dose combination, it's bioequivalent under the fat condition to the individual reference product, and we hope that once again this fixed dose combination can offer a good treatment and easy to use alternative to the patient. Thank you.
Thank you very much. So the next presentation is by Dr. Patel, and it's on the population pharmacokinetics of cabotegravir in healthy subjects and HIV-infected patients following administration of oral tablet and long-acting intramuscular injection.
Thank you, Marta. I tried my best to make the title short, so I think I won here on this round. On behalf of my collaborators, I want to thank the organizers for selecting our abstract for poster discussion today. So cabotegravir is an HIV integrase inhibitor in phase 3 development for both the treatment of HIV infection in combination with long-acting rilpivirine and as monotherapy for HIV prevention. Cabotegravir is unique in that it has physiochemical properties that has allowed its development into a long-acting agent for intramuscular administration. Following an IM injection, cabotegravir exhibits an extended absorption profile, which provides for a long duration of action. Now, we know that variability in absorption could lead to variability in drug exposure. So we decided to undertake a population PK analysis to evaluate what factors influence parameter variability. We wanted to understand if the presence of any of these factors translate into important changes in drug exposure. And further, this data would help us understand whether there is a need to optimize the dosing strategy. Our initial phase 1 population PK model was updated to include data from 881 patients and healthy volunteers across phase 1 and phase 2 studies. This represented nearly 12,000 samples following oral and long-acting administration. Importantly, with this update, we more than doubled the number of females to 20% of the population. In our analysis, a two-compartment model with first-order oral and IM absorption continued to describe the data well. And consistent with our early model, we found that female gender, BMI, and split injection dosing remain factors that influence the variability on absorption rate. However, the magnitude of change on absorption did not alter trough levels to a clinically significant extent. These covariates altered trough levels by less than 15%. Now, the majority of variability attributed to the absorption rate parameter was influenced by female gender. So in our model, for a typical female, would have a 57% slower absorption rate and a longer persistence of drug in the body. Now, BMI and split injection dosing gave a modest influence on absorption, such that after accounting for gender, a large BMI causes a modest decrease in absorption. So going forward in phase 3 studies, we are not employing split injection dosing, primarily to reduce the number of injections that individuals would have to receive at a single dosing visit. So again, to reiterate, the factors that affect PK parameters do not affect trough levels, and this can be seen in the simulations. So on your left, you see the simulated PK profile for the 400 milligram monthly regimen, and then to the right, you see the corresponding profile for the 600 milligram every 2-month regimen. Both regimens result in trough levels that are above those required for efficacy, and these simulations are consistent with the observed clinical data from Latte 2 in patients. The 3 different lines on the graphs represent 3 different concentration thresholds, and again, the median and the variance are within the therapeutic range for efficacy. So cabotegravir PK, as tested within its clinical trials, supports effective monthly and every 2-month regimens without the need for demographic-driven dose adjustment. In fact, we originally selected our dose levels in part because we understood the influence of female gender and body size on absorption so that we could avoid the requirement of having a dose adjustment based on these factors. So I'd like to encourage you to visit poster number 205 today for details of this analysis, as well as to visit poster number 84 tomorrow, which describes the adherence patterns from our phase 2 Latte 2 study who received both of these dosing regimens. And we continue to remain excited about cabotegravir and its potential and look forward to the results of our phase 3 treatment studies in order to bring this important treatment option forward for patients. Thank you.
Thank you very much. So the last presentation of the session is by Dr. Tikiso on TB HIV co-treatment with super-boosted lopinavir and anti-tuberculosis treatment low abacavir concentrations in children. And I think we will manage to actually have the poster up. Thank you. If you want to talk through it for 5-7 minutes.
Good morning, everyone. My name is Chokosala Tikiso, and I would like to thank our collaborators, DNDI and Stellenbosch, for doing this. TB is very common in HIV-infected individuals, especially kids. And rifampicin has been shown to reduce lopinavir exposure. We did a study where we super boosted lopinavir, and then that showed that the exposure got back to what was expected before, so it kind of fought off the rifampicin effect. So what we did was also to check and see what this impact had on abacavir, because we know that it has been shown that abacavir is also decreased, exposure is decreased when given with lopinavir and ritonavir, but then we are not sure really about how the impact of this, what's the impact of this. So in this study, we use population pharmacokinetics to try to explain or find out what might be the reason or what's going on. So what we did was use non-MEM, which is a software for population pharmacokinetics, and then we found a two-compartment model, first order absorption and elimination. We included allometric scaling on weight and volume, and then maturation. What we found was that there was a 38% decrease in bioavailability between visit 1 and visit 2. By visit 2, I mean visit 1 and 2. Visit 1 is where the kids were getting lopinavir, ritonavir, which was super boosted. And then visit 2, they were getting normal lopinavir, ritonavir with abacavir. It was not super boosted. So visit 1, they were super boosted. Visit 2, they were not super boosted. So we found that when the kids were super boosted, there was a 38% decrease in bioavailability. We also found that there was a huge difference in trough concentration, I would say, between the night and day concentration. It seems like the morning concentration were higher than expected. So we assume maybe this might be because of circadian variation. We're not completely sure about that yet. And also the impact of this 38% decrease in bioavailability. We are not sure about what it basically means, because at the end of the study, 82% virological success rate or kill rate was found in kids. So basically there was a good cure rate at the end of the study. So we are not sure what this means in terms of abacavir with a low 38% decrease. So I think the next step now will try to be to find out what kind of impact this might have on these kids. Thank you.
Great, thank you very much. Any questions for the presenters? Any comments for discussion? So I'm just going to start while people walk to the microphones. Can I have a couple of questions for Sabine? Huh? Sorry. So two short questions, actually. One is whether you think that the rate of fast metabolizers that you found in Tanzania and Ethiopia is different than what has been reported in the literature in other African countries where, for example, the STRIDE study took place, so where other investigations on treating TB with efavirenz, treating TB with rifampicin in people on efavirenz have been done, and whether there was an impact on virological response in the people with the low efavirenz concentrations.
Thank you very much for the question. Yes, so we found 50% of the cohort being the fast metabolizers or rapid metabolizers, which is quite high in comparison to other African countries, whereby, for instance, in South Africa, I think they're seeing about 30%. South Africa and Western Africa, they see about 30% of fast metabolizers. And within the East African region as well, a study done in Uganda and in Burundi have also reported much lower proportions of the fast metabolizers in this population. However, our cohort showed that they had a 87% virological suppression among these patients, and I think it was comparable with the other countries.
Great, thank you. So suggesting that maybe 1,000 cutoff of efavirenz is a bit high and lower concentrations still work.
Yes.
I would add, if you agree, because you've done the study. Okay.
Yes, I would agree, because the other cohorts that included the HIV-only patients as well showed similar distribution of the metabolizers.
Thank you. Microphone 3.
Thank you very much, and to all the presenters. It was very interesting and straight to point. My question is actually to Dr. Mugusi again. Sorry, this is very basic, and it might sound a bit dumb, but I just need to be clarified on it. So you've got children, the participants who are actually coming from Ethiopia and Tanzania. So I was wondering whether they were all placed on the same set of treatment, like the treatment regimen they were on, was it the same for both Ethiopia and Tanzania? Then the second question is there a reason why you were comparing Ethiopia and Tanzania, or it's just a random comparison of two countries that you picked up? Just need to clarify on that. Thank you.
Thank you very much for the question. So these were adult patients, they were not children, so they were adults aged 18 and above. Because of the time limit, I couldn't have gone over all the details, but at that time, so the study was done between 2008 to 2010, and we had similar treatment guidelines, which required the patients to have started antiretrovirals when they had a CD4 of 200 and below. And the treatment, so the drugs were basically the same. So it was first line, so it was, at that time, we were still using stavudin, lamivudin, and efavirenz, and zidovudin, lamivudin, and efavirenz. So it was similar in both countries. Coming to the question of why we selected Ethiopia and Tanzania, they're ethnically different. So we believe that genetically they would also be different. So the Ethiopians are mainly Semitic and Cushitic, whereas Tanzanians are mainly Bantu. So these have shown some genetic, pharmacogenetic variation. So that's one of the reasons why we also selected the two. Yeah.
Thank you. Microphone 2.
Thank you. I have a question for Dr. Patel. In the Netherlands, we see more and more extreme obesity. And could you comment on injecting carbotekravir in patients with BMIs above 35 kilograms per square meter?
Yeah, no, that's an excellent question. So that was one of the things that we were very interested in understanding, is what impact does a higher BMI have on the absorption rate? And as I mentioned, overall on the influence of the variability on the absorption rate, the leading factor was gender. So that's 57% slower in females. And we really think that it's more because of the amount of fat thickness overlying the muscle. So then when we accounted for gender and then said, okay, what if that individual was also of higher BMI, what additional impact would we have? The impact on the variability and absorption rate was only about 18%. So we believe, with the data that we've accumulated, that you only have a modest additional impact from higher BMI on the slower absorption rate.
I have a question for Dr. Patel too, if it's okay. Sorry, it's just, so do you think there is anything else that we need to study? I'm quite happy personally, but just like for the clinical care provider that understand and pharmacology, is there anything else that we need to study to actually be reassured that the inter-individual variability of cabotegravir, especially the injectable, because obviously that is the innovative drugs that we're waiting for, that anything else needs, to reassure us that it's okay, and the dose selected and the time interval that you can think of, or this is probably it? Sorry, it's not an easy question.
It's a very good question. I think, obviously in our clinical trials, we try to accommodate a diversity of individuals, obviously gender, body size, age, racial demographics. I think one of the items that I'm personally interested in learning more about is individuals who are elderly. So we know that there's an increasing prevalence of HIV-infected individuals above 50, and they may have differences in the relative contribution of fat versus muscle. And so I'd like to be able to, evaluate that as well. We do have in our model individuals with BMIs as low as 16. And so we do have some information in individuals who may have lower muscle mass, but certainly if we had the opportunity to look at, that demographic, that would be especially important. And we are also doing our pediatric studies consistent, with our phase 3 adult studies. We're starting with our adolescents and we're moving down. So that will be another important population for us to evaluate the dosing regimens and any dose adjustments we may need to make as a result of scaling down for size.
It's really useful because I imagine the clinical trials that you use, although the number of patients used is massive and all healthy volunteers, the age is always a limit, isn't it? So that's great, very useful. Microphone 2.
Yes, I've got a practical question for Dr. Gawai. About the lopinavir-ritonavir granules, you looked at the bioequivalence in fat conditions, under fat conditions. So what was the composition of the breakfast you gave, and is it comparable to what children in Africa would get?
The breakfast, it's a standard veg breakfast, which is around 800 to 1,000 calories. Generally recommended by the WHO conditions. So that was considered for the study. I may agree with you, it may not reflect exactly the situation with the patients or the pediatric population. However, the study was conducted under the standardized condition so that we get the results which is linked with the formulation.
Yeah, and are you planning to check the concentrations in children when they take it, for example, in Africa, or can you just roll it out and let's see what happens?
I think it's a good suggestion. Probably, maybe we'll take the suggestion, and going forward, we'll see how we can address it.
I keep going. I can ask all the questions I want. That's superstar. You can stay here until tonight. So one question for Dr. Tikisi about abacavir abacavir concentrations in plasma, right, being decreased. Are they still within the ranges of previously measured concentrations in the literature? So are you actually worried that there's not enough abacavir there for entering cells and for the active metabolite to be phosphorylated? Because it didn't seem to have an impact on viral load, right? Are you planning, so you said you were planning future studies. Are you actually planning to look at the active intracellular level, or you're just looking at pharmacodynamic and virological response, which is correct because of how difficult, it is to measure drug in cells? What's next?
Yeah, sorry. As you just said, it's a bit tricky, because especially like if you give with ARVs are always given together, so it's always hard to kind of pinpoint one. But then from the doses which we got, they're not the same as what you got in literature a bit, but that's plasma. So as you say, we have never yet checked to see intracellularly how that is. So the best step, obviously, to kind of get the right measure would be to check the intracellularly to see if the drugs are really reaching there and how much is getting there. So I think that would be the next best step, but that we haven't yet discussed that. I think that's another thing which the team will have to talk about, because this was something which was, obviously it was not expected. So now that we have the results, it's more about to sit down and see which one is the best strategy to do. Yeah.
Great. Any other questions, or you want to go home early? Thank you very much.